Okay, so we have Dr. Sunny with us. He's our candidate. Dr. Sunny, please read the case for us.
So I have a 28-year-old female who wants a oral contraceptive. So in the next 10 minutes, I need to take a proper history and counsel the patient. Okay.
Okay, so the question is saying take a history and counsel the patient. Okay, so your 1 minute to prepare yourself starts now. Then when it is up, I'll let you know. Then we can start conversation. So this whole thing is, it's like in the main exam, you will have a door. You'll be standing behind the door. When you read the case, you have 1 minute. So you'll be standing behind the door for 1 minute. So that's what Dr. Sunny is going to do. Okay. So let's start. Your 1 minute starts now. When the 1 minute is up, I'll let you know. And remember, you have just 10 minutes for this case. Okay. And then, doctors, as he's doing it, I want you to also be typing in some of the things you'd have thought about. And I also want you to type in some of the things you think he should be talking about if he misses any of that. So that when he's done, we can all jump in, criticize, give feedback, That's very good. So I'm getting my paper to score him. And then, take it from there. So we are waiting for Dr. Sunny's 1 minute to be up. And then we can get into the game. Dr. Sunny, your 1 minute is up. So let's go. I'm going to unshare my screen. So when I unshare the screen, it's like Dr. Sunny has opened the door. He's coming to the room. Let's go. Hello, Dr. Sunny. Your 10 minutes starts now.
Yeah, hi. Hi, my name is Dr. Sunny. I'm here to help you today. Can I know your name, please?
I'm called Mary.
Okay, how old are you, Mary?
Doctor, I'm 28 years old.
Okay, wonderful. Can you please give me your address? Where do you live?
Oh, I live in Ontario, Sunny Bay.
Okay. So what brings you today, Mary?
Doctor, I'm thinking that I want to start some oral contraceptive pills. Is that okay? Can you prescribe that for me, doctor?
Yes, that's a good start. That's a good start. We can do that. Before we go to that, let me get a little detail about how your life has been so far.
Okay.
Is that okay?
That's fine with me, doctor.
Okay. Are you married, Mary?
No, doctor.
Okay. When was your first cycles, Mary? When was your menarche?
My menarche was at 14 years old, doctor.
Very good. Have the cycles been regular as such?
Yes, it's regular.
So you get your cycles every 28 days?
It's every 30 days.
Okay, very good. And how long does your bleeding last for every cycle?
About 5 days, doctor.
Okay. And can you describe me how the bleeding is? Is it too much? Is it normal? How many pads do you change per day whenever those episodes happen?
Doctor, please, which question do you want me to answer?
How many pads do you change per day whenever you have your bleeding?
I change about 3 parts a day, doctor.
Okay, so that's not bad. Okay. Apart from that, do you experience any abnormal amount of pain during your cycles?
No, doctor.
Okay. Have you ever been diagnosed with any thyroid issues or any other issues as such?
Doctor, I've not been diagnosed with any thyroid issues. And which other
Have you
issues did you
experienced?
want to know?
No, I wanted to. Okay, let's break it into symptom wise. Have you experienced any recent weight gain, weight loss?
No, I've not gained any weight, doctor.
Okay. Sure. So are you taking any regular medicines as such?
No, doctor.
Okay. How is your sexual history?
Um,
Have you been sexually active?
I'm planning to be. I have a new
Okay.
boyfriend. We've been
Okay.
dating for 2 weeks, and I know eventually this thing will come up. That is why I want to get this oral contraceptive pill, doctor.
That's a good step to take forward. Just want to make sure that you've never had it before, right?
I've never had what before, doctor?
You've never had sex before, right?
Oh, no, I've had past boyfriends and yeah. We've
Have
engaged.
you used any contraception before?
Yes, doctor.
Okay, what method were you using?
I was using a condom, doctor.
Okay. Okay, so based on what we have here, we have multiple options for you. Okay, so ideally, we obviously, if you understand the method, since you've already used condom method, so you know how a condom can help you prevent pregnancies. We again have pills as well. Those are oral contraceptive pills. Again, they have their ups and downs. Everything, every medicine that we take which alters our physiology will always have their ups and downs. Other devices that we can do is other options that we can have is we have intrauterine devices where you can insert a copper T and it will help prevent pregnancies. Another thing that we can try is a female condom, which would also have have its up and down there. Ideally, it all depends on what you find comfortable with and how you want to go forward with. So, do you have any questions to me for among these options for now?
Well, I was thinking about the pill. That's what I was thinking about.
Okay.
Yeah.
Okay. Sure. We can start you on your pills. I just wanted to briefly confirm. I forgot to mention that. I forgot to ask you this. Do you have any family history of breast cancer or ovarian cancers among your in your family?
No, doctor.
Okay, that was important to get rid of. So we have our oral contraceptive pills, which you will be taking every day for your 21 days. It'll go along with your cycle, and then we have 7 pills, which would sorry.
Dr. Sunny, please go on.
Yeah. So yeah, these oral contraceptive pills work in such a way that we would be giving you pills for each month. You would be taking these pills every day every day a single dose of these pills. You'll be taking them for 21 days. These are going to be a hormonal pills, which will try to alter your hormonal levels in a way that it can prevent any fertilization. Additionally, we'll also be prescribing you the next 7 days will be your iron tablet pills because we don't want you to lose iron as such. Before we start any these medicines, I would like to get a few tests done. Is that okay with you?
Sure, doctor.
I would like to get your baseline hemoglobin so we can get a rapid CBC. We can just get a CBC done. I would like to get your baseline hemoglobin and that. Can I? I would also like to just check you for thyroid so that we make sure that we're not dealing with anything subclinical so that we don't trouble them. Additionally, it would be good to get a UPT done because when was your last cycle? Just to check again. When was your last cycle?
About 2 weeks ago.
Okay, so then we are good from there. So I would like to get your
Doctor,
basic.
please, doctor, you just said UPT. What is UPT?
No, yeah, okay, very good question. I wanted to get your urine pregnancy test, but the only reason I would want to do that is before starting any contraceptive pill, I wanted to make sure that we've not had any previous pregnancies. So I wanted to get a UPT done. But since you've had your periods from the last couple of weeks ago, so then I'm happy to not get a UPT done right now.
Okay.
You have any doubts there?
No, you are the doctor. I'm just following what you said.
No.
Yeah.
Okay, so as I was saying, I would like to get your basic hemoglobin. I want to get your iron studies, and then we can start your pills from then.
Okay.
Do you have any questions for me?
No.
Was I clear in my information?
Yeah, doctor. Is that all you want to let me know?
Okay, so there are a few things that I want you to tell one since we're going to start. Since you're confident that you can start the OC pills, there are a few things that I want you to understand about these pills. See, every day take only one pill. Okay, do not. So if you're taking a pill today at 5 p.m., make sure you take the same pill again next day at 5 p.m. In case you miss a dose, do not double up on your dose. If it's close to your second dose, do not double up on your dose. Uh, Ideally, you would experience no nausea, no not any major side effects. Sometimes you might feel a few flashes. That's common. That's gonna be normal because these are hormonal pills, and you could expect certain amount of them to happen. Yeah, that's about the information I had for you with regards to your medicines. So yeah, I think we're good for now. I hope my information was clear.
Yes, doctor, information is clear.
Thank you. Maybe have a good day.
Thank you, Dr. Sunny. Thank you very much for talking to me. Okay, good. So Dr. Sunny used 8 minutes, 26 seconds to get through the case. Class, how did he do? How did he, if you were supposed to score him, what will you score him? Was it acceptable, unacceptable, borderline acceptable, borderline unacceptable, above? What will you say? And you have to give me reasons why you think maybe he scored, you are giving him this or that. Is there something he did that was unique for him and a learning point for you? Is there something he did that you think, oh, maybe he should do something different? I want to hear from you before I bring in, my contributions. Dr. Sunny, by the way, how was it? How was the experience?
I liked it. I heard a recorded version last time, and I thought I should give it a try next time. So I'm really happy how this went, because this is
Okay.
how I think probably we learn, by doing the practice.
Sure, yeah. So, Dr. Afsana, you just said history is not complete, I think. So, Dr. Afsana, what would you have added to the history? Tell me. I like it when class members are able to bring up, contributions towards the discussion. Dr. Afsana, you can unmute yourself and we can have a conversation. What would you have added? Dr. Kim also says family history. Dr. Kim, please prepare. You will bring up your contribution. Okay, Dr. Afsana just typed in hypertension, migraine, diabetes, DVT history. Dr. Sani, so your own colleagues are pointing out certain things that they think you should have hit on: migraine, headache, history of hypertension, diabetes, or DVT. What do you think about that, Dr. Sani? I'm bringing it back to you. I'm throwing it back to you.
I certainly feel I should have taken DVT. With regards to hypertension, migraine, I asked, do you have any chronic illnesses for which you're taking medicines? DVT, I cannot ask directly, but I should have had a proper question for related to that.
Okay, sure. But then, when it comes to something like oral contraceptives, there are specific questions you want to ask, right? Even if, do you have any past medical history or any medications you are taking? If I even say no, there's some specific things I need to do, like, do you smoke? Do you, some specific things.
Absolutely.
Okay.
True.
Dr. Kim, would you want to unmute yourself and just throw
Sure.
in something? Yeah, please bring in your
Sure.
contribution.
So let me just add that I think he did well, given that it was just maybe something that was impromptu. And like counseling is not the first thing that comes to mind. I mean, yes, we should be preparing for it, but it can be a bit difficult. So he did well because it was impromptu, but there were certain things that he left out, like, history, family history, social history, personal or past medical history, which is important when it comes to choosing the correct contraceptive, right? So in order to rule out the possibility of giving the different forms because of the complications that might be associated with it.
Sure. Beautiful. Dr. Momand. Dr. Momand, Dr. Sani, this is Dr. Momand's contribution towards your case. Dr. Momand says, I think Dr. Sani did a good job. Instead of marriage, we may ask if she's sexually active. Or I think Dr. Momand is asking a question. Instead of marriage, may we ask if he's sexually active? Yes. Dr. Anna's iPhone says premenstrual symptoms. Okay, so these are a few things, and I want to bring up some things. Dr. Sunny, you did very well. Okay, very, very well. There are some things I want to point your attention to. There were a number of leading questions. Leading questions. How regular, like you said, when it came to my cycles, you said, are your cycles every 28 days? Maybe you could have put it this way, because it's not only 28 days, which is considered regular, right? You could have put, okay, how regular are your cycles? Or how many days do you usually in between cycles do you have? When it came to the number of bleeding days, you did it very well. You gave an open-ended question. Okay. But then, especially when there are options, You don't want to just stick to one. And then remember that there
It
was
should be a range.
Exactly. Remember that there was a time I asked you, doctor, which question do you want me to answer? Because you asked about 3 questions together that, do you have this, and that? And then I was like, okay, doctor, which one do you exactly want me to answer? You want to avoid what we call sandwiching.
Multiple questions.
The way we prepare sandwich, right? It's like you put everything together and you bite it, boom, and you expect the patient to taste it and say, oh, this tastes good, so I'm going to answer this. No. You want to be clear and make sure that you don't ask more than 2 questions at a time, eliciting for an answer. In fact, it would be good to just ask 1 question, and then get the patient going. And it's good. Frankly, I really liked the way it was not like you were interrogating me, but it was like you were having a conversation with me.
Okay.
I really like the tone, because it was like a friendly tone. It was not like, do you do this? Do you do that? It was not regimented. It was more like you give, I give, you take it back, you reason through it, and then you bring more questions. And then you remember that you said something. I was like, doctor, what is UPT? Right?
Yeah.
You are a doctor, I am a doctor, so I can state it. But from the concept, from the perspective of a patient, what is UPT? What is Wernicke's encephalopathy? Those things.
Yeah.
So even if you are going to use, have you had a UPT? Quickly, you want to add, well, a UPT is urine pregnancy test. You don't want the patient to rather be asking, doctor, what do you mean by that? Or in order to get yourself out of that trouble, then what you can just do is keep this language simple. Have you had a pregnancy test using your urine? Then it becomes very simple. And then I think that, when you had about, you got to 8 minutes, and I know you were not probably looking at your time and all those things, but there were other things you could have added to fill in the space, just to also get some other marks. So let me share my screen, and then let's go through maybe some stuff. And then I think that you also said something. What is your address? It's not something we ask, right?
Yeah, it's in our country practice that we usually take the address. So I did that thing over there.
Yeah, the reason is because, you know what, in Canada, before the person comes to you, you already have the person's demographics. And most of the time, the person's phone number, the person's address, and all those things are there. The only time you may want to ask about your phone number and your address is maybe if the patient calls you telephonically by phone, right? The reason why you're asking is that maybe assuming it's an emergency and the phone drops, because you already have the phone number, you can call the patient back. Because the patient may be so sick that the patient may not be able to have the strength to dial back. But for a patient who has come in, most of the time, for a patient to come into you in the clinic or even in the emergency room in Canada, in the Canadian context, you already have the demographics, where they live, their address, their phone number, the contact of their emergency contact. It's not you, the doctor, who is going to ask those questions.
Okay.
So the concept of jurisdictions is a bit different. So I wanted to just bring that in. Okay. So what would have been my approach? Maybe wash my hands, but this did not really need a physical exam. So okay. And then but if you go there, you go into the exam room and there's like a hand sanitizer, you just want to use it. Introduce yourself. Hi, Mary. I'm Dr. Sunny. I'm in the NAC OSCE clinic today. How may I help you? Don't forget that maybe this patient's name has already been given to you. If the patient's name has already been given and the age has already been given, it's a bit awkward to go and ask the name and the age again. Okay, so that is one thing. So you can frame your introduction this way. Hi, Mary. I am Dr. Sunny. I'm in the doctor in the NAC OSCE clinic today. In the next 8 minutes, in the next 10 minutes, in the next 11 minutes, I'll be speaking with you to evaluate your concerns and how best I can help you. Is that okay with you? When you do this, what is happening is that it's like you're setting parameters for the conversation, that this conversation is going to last 8 minutes or 9 minutes or 10 minutes, and you've sought the patient's consent. And then you go like, so please, how may I help you today? When you say, how may I help you today? What you're doing is that you are setting an agenda. And you are letting the patient know that I am here to help. I'm here to guide. I'm here to support you. Because remember that we said the NAC OSCE is set in the context of the CANMET's rules. All right? Okay, good. So now, some specific questions you want to ask. Why does the patient want an OCP? Remember that when you asked me, I said I've used condoms before. So if I used condom before, why do I not want to continue with the condoms? That's a very critical question to ask. Or what raised your concern about OCPs? Maybe the patient will say, oh, I had a friend who said they were using condoms, but the condom failed. Then that means that you have a room to educate the patient, because the fact that the patient wants oral contraceptive pills does not mean that the patient is necessarily a good candidate for oral contraceptive pills. Hello, Dr. Sani, are you following me? The fact that the patient is asking for oral contraceptive pills does not mean that the patient is a good candidate for it.
Yeah.
So yes, if I find out why are you not continuing the use of oral contraceptive, and the patient says this, that, and that, I keep that in mind. So when it gets to the counseling session, I will know what to tell the patient. And then the next thing is, you also want to know, how much does the patient know about the thing the patient is inquiring? So if the patient is talking about fertility wish, if the patient is talking about medical assistance in dying, if the patient is talking about a particular medication, you want to know, how much does the patient know? Because as the doctor, you want to know whether the patient has any false beliefs about that particular thing, or maybe the patient's beliefs about that particular thing are correct. Then you just continue. You just fill in the gaps. So you're asking the second question, what do you know about oral contraceptive pills? Basically, to help you to appreciate, the knowledge that this patient has. And if it is good knowledge, you emphasize it. If it is bad knowledge, then you want to take advantage of the situation to advise the patient either way. Are we all on the same page? Then, how much do you wish to know about oral contraceptive pills? Have you had any previous use of oral contraceptive pills? Any other forms of contraception in the past? I told you already, condoms. If yes, why was it stopped? Well, doctor, I stopped it because my friend and her partner were using it and it failed. And I'm afraid I don't want to get pregnant. Okay. Is there a possibility that the patient could be pregnant? Inquire about the last menstrual period, which Dr. Sani did. Any plans of getting pregnant anytime soon? Because if the patient has plans of getting pregnant in 3 months, and the patient comes saying, doctor, I want Depo-Provera injection. Red flag. Why? Because we know that at times when patients get Depo-Provera injection, it prolongs the time of their fertility. Right? But the patient says, doctor, I have projects ahead of me. I have to attend school. I have to attend business meetings. I'm in the early stage of my career. I don't want pregnancy to come and, destroy my career. And therefore, I'm not planning on getting pregnant in the next 5 years. Okay. Then we can look at something like these other contraceptive pills. Okay. Are you a good pill taker? Some people, even a 3-day course of antibiotic or 5-day course of azithromycin, they can't finish it. How much more somebody taking a particular pill every day till they decide not to take that pill again and get pregnant? Any concerns about any other form of birth control? If yes, what bothered you about it? Well, doctor, like Dr. Brony, I'm afraid of needles, so I don't want any Depo-Provera injection. Okay, then you want to go through some specific questions. And then let me show you a trick. In NAC OSCE, we have something we call signposting. And I think you were doing it, which was good. So signposting, for example, Mary, I would like to ask you some questions about your gynecological and your sexual history and other issues that can help me to know whether you are a good candidate for oral contraceptive pills or not. Do you know why? When you say this, it looks like you are directing the examiner that, hey, we are going into the realms of contraindications for oral contraceptive pills. You wouldn't tell Mary, I'm going to ask you some questions about contraindications for oral contraceptive pills. No, you're rather going, Mary, I'm going to ask you some questions which will help me to know whether this oral contraceptive pill you want to take, you are a good fit for it or not. You see, this is simple, everyday language, but it helps the examiner to know where you are going. You know, signposts is like when I'm traveling to Toronto, I see on the way 2 minutes to Toronto, then I prepare my mind. Okay? Because at times the examiner may not be paying so much attention, and then you may be asking your questions, boom, 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 and the examiner might not be able to follow you. But when you signposts, it helps. And that is one of the tricks we teach in MedCognito. In fact, those in the course, you realize that there's a folder called Communication Like a Pro. Please, if you've not finished it, make sure you finish it. Okay? Make sure you finish it because it's very, very important. Okay, so let's continue. So the signposting, any sexually transmitted illnesses, pelvic inflammatory disease, abnormal vaginal bleeding, migraine headache, maybe with aura, fibroids, diabetes, past history of blood clots, heart problems, past history of cancers. And I think those cancers, you went into them. Active liver disease, you want to ask about all those things, okay? And then you want to get into the menstrual history. Age of first menses, which you asked about, is the menstrual flow regular, irregular? You asked about it. How often do you menstruate? You asked about it. How long does your menses last? You asked about it. How many pads do you use when you menstruate? You asked about it. Any pain during menses? So it looks like the menstrual history, you really killed it. Any bleeding in between periods, last menstrual period, is it possible you may be pregnant? We've already gone through that already, okay? And then any use of any birth control pills or in the past, any other form of hormonal contraception, do you do your pap test regularly? Very important. If yes, when was the last one? Because at times the patient might have come for oral contraceptive pill, but because you're going through all these gynecological history, it also helps you to maybe book a follow-up appointment that, oh, Mary, maybe you are 32 years, but it looks like your last pap test was done 5 years ago. So even though you didn't come for pap test, I want to schedule a pap test for you. You come across as a very competent doctor. Dr. Sani, what do you think about that?
I'll have to thoroughly read up on what are the schedules of PAP to be done.
Exactly.
So that I could have done that.
Yeah, beautiful. So what was the result of the last pap test? Any gynecological intervention like dilatation and curettage in the past, okay? And then when it gets to sexual history, you know that people talking about their sexual history with a stranger, in as much as that stranger is a doctor, is not easy, right? So you can give what we call a warning shot. Now look, now I'll be asking you some sensitive questions. Unless otherwise requested by the law courts, be confident I will not disclose this information to anyone. Please, is that okay with you? Then, because it is very awkward for you to just go, do you have intercourse? Who do you have intercourse? Like, but when you give that warning shot, it's like, oh, something is about to happen. Are you sexually active? If yes, since when? How many partners have you had now? How many have you had in the past? Do you practice safe sex? And then you quickly go into explain. Safe sex basically means do you use condoms, any history of vaginal discharge, any urinary problems, any abdominal pain, any history of STIs. You go in and you ask all those questions. Partners past history of STIs. Doctors, please. Are we all on the same page? Is this broadening our horizon? If
yes,
yes,
it does for me
yes,
at least.
yes, beautiful. Yes. Type in, let's go. I really want to make sure you are not sleeping behind your computer or your phone. I really want to make sure you are tracking with me. So that's why I'm always asking for feedback. Yeah, okay. So then you go through the obstetric history. Have you been pregnant in the past? If yes, how many? Okay. If the patient says no, then there's no need to go through any further obstetric history. Have you been pregnant in the past? No. Then there's no need to go through any past obstetric history. But if the patient has been pregnant before, then you want to take your time. Okay. Then past medical history, past history of chronic illnesses, past surgeries, blood transfusions, allergies, medications. If the patient is on any medication, you want the patient to list them. Why? Because there are some medications which can interact with oral contraceptives and either render them ineffective, and any recent laboratory results that I should know about. What about your immunization? These ones, they are just, they're just going on and on and on. And any lifestyle issues I should know about. And then family history of any medical conditions, family history of any blood clotting. And then you want to go into their personal history just a little bit. Your education, your work history, your finances, your social support, your religion. Because some religions are against some forms of contraception, right? So you want to touch base on all these things. Dr. Sunny, so you realize that you could have gone to town a little bit more on the history aspect. Don't forget, as I told you, about 6 to 7 of your cases will be purely history. But this was history counseling. Yeah. So you want to, whenever you feel like, it looks like I've finished way ahead of time. Be careful. All right? Be careful. And then another thing I really wish you could have done is what we call the concept of fifing, F-I-F-E. Please, this one, everybody write it down. Or you can take a screenshot of this, please. The concept of fifing. Any patient you see, any patient encounter you have, please do your best to fife the patient. Even those who are writing the Canadian College of Family Physician exam, CCFP exam, their oral exam, they're expected to fife. What do I mean by that? F stands for feeling, I stands for idea, F stands for function, and E stands for expectation. What do I mean by that? What does the situation of you having a boyfriend for the past 2 years or past 2 weeks and you wanting oral contraceptive feel, how does that make you feel? Because the patient may say, look, I'm happy about it. He's my boyfriend. I'm happy about it. The patient may say that. What are you thinking about? Or what do you think is going on? And then how does this affect your day-to-day activity? Or how does this affect your relationship with your partner? Well, doctor, because we don't have any form of contraception, we've not been able to, have any consensual intercourse or anything like that. Okay. And what are you expecting from this encounter? And the patient may tell you, I am expecting that by the end of this encounter, I will get a script for an oral contraceptive pill. So after you've done this, then you move into the counseling session. Okay. So I'd like to bring to your attention on situations in which it will not be advisable to use oral contraceptive pills. In the medical language, we call that contraindications oral contraceptive pills. So you see, you can use the word contraindications, but it's about how you put it. So do you have any history of liver disease or liver cancer, history of uterine cancer, or impaired liver function, or hyperlipidemia, where the patient is more than 35 years and smoking? Is there any history of Wilson's disease? Or what you can do is also that, from the history, you told me that you don't have any history of liver cancer, uterine cancer, impaired liver function, high cholesterol, migraine with aura. So it looks like you don't have anything which will prevent you from getting onto oral contraceptive pills. So it's like you are borrowing information from the history to help you with your counseling. Simplicity. Dr. Sani, is that okay? Remember, it's all about communication. Okay, let's move on. And so, other things which will prevent you from using oral contraceptive pills can be current pregnancy, undiagnosed vaginal bleeding, active cardiovascular and thromboembolic diseases, proliferative retinopathy, or like severe eye damage, history of breast cancer. Do you have any of these? No, it looks like you don't have any of these. So it looks like you are a good candidate for it. Now, because we are talking about a medication, you also want to tell the patient how the medication works. So we've looked at the contraindications. Now we are going to look at how the medications work. So these oral contraceptive pills, they usually contain estrogen and progesterone, or just progesterone. And this is how they work. They work by preventing you from releasing your eggs or prevents ovulation. They also make the lining of your womb thin, so that it does not become a conducive place for the fetus to implant. And it makes the mucus of the cervix thick to prevent sperm penetration. So these are the things you want to talk about. And then after this, Dr. Sunny, so you see there are a lot of things you could have gone through, right? After this, then start talking about the benefits. The benefits. And we talk about A, B, C, D, E's. Okay. So A is anemia reduced. Why? Because oral contraceptive pills reduce the rate of flow, or to reduce the amount of flow. And therefore, the patient usually becomes anemic during her menstrual cycle. That will reduce it. Often it also clears acne, because a lot of females may be very conscious of their body image. So if you let them know that there's one pill, it will reduce their flow rate, it will reduce acne, and it can also prevent pregnancy. My goodness, the patient is killing 3 birds with 1 stone. The patient will look at it. It's also benign breast disease, and cysts are decreased. It also reduces certain risks, like ovarian cancer is reduced, cycles become regulated, and there's increased mucus, which reduces STDs. And then dysmenorrhea is decreased. So, in case you have pain when you are menstruating, dysmenorrhea will become decreased. And virtually no chance of pregnancy when it is taken as directed, because it has almost a 98 to 99.5 efficacy rate. Right? So you take your time and you break all these things down. But then, after you talk about how it is used, the benefits of its use, its effect, you also have to talk about the risks associated with it. Possibility of weight gain increases the risk of DVT, especially when it is combined with smoking. Breast cancers, it does not provide complete protection against sexually transmitted diseases. So in case you're concerned about sexually transmitted diseases alone, then oral contraceptive pills are not the contraceptive of choice. Okay, you may need a backup plan like a condom. Okay, so let's see how to use OCPs. And I think you went into that. So you want to start the OCP on the first day of the next menstrual period. Place the package in an obvious location to help you to remember it, like close to your toothbrush, because almost everybody will brush their teeth in the morning, right? Or close to your alarm clock. So as soon as your alarm clock goes, you can pick up the oral contraceptive pill and take it. Or close the dressing mirror, because almost every female would like to stand in front of the mirror, toss the hair a little bit before they go out of the house. Okay, you must take it at the same approximate time each day. And use additional contraception for the first 2 months, as oral contraception is not reliable until then. And if you miss a day, take 2 pills the next. If you miss 2 days, take 2 pills for the next 2 days and use an alternative method until the next period. Okay? And give prescription for OCP of choice. Then you ask, maybe you have any family member who also uses any form of oral contraceptive pill. The patient may say, maybe Alicina, Alice, Ovima, they have all sorts of names. And because maybe the patient may have a sister who used a particular form which helped, maybe you may want to try that as well on the patient, because maybe the patient might have already talked to the sister about it. Okay. Awesome. And then you have to let them know there are the 21-day preparations and the 28-day preparations, and there are other hormonal contraceptive options like Depo-Provera, which is given every 3 months. So even though you are counseling about oral contraceptive pills, you also want the patient to know the other forms of contraception. Depo, implants, IUD, still go back to condoms, even some form of permanent contraception as well. Because who knows, maybe this patient does not have any wish of bearing a baby at all. So closing remarks. This is where I was expecting Dr. Sunny to maybe ask some more probing questions. For example, any concerns for me? Now, Mary, I'd like to go ahead and check your BP and send you to the lab for a pregnancy test. Is that okay with you? I'd like to follow up with you in about a month. Is that okay with you? I would like to also give you a handout. Dr. Sunny, you see, you can easily print out some information about oral contraceptive pills and give it to the patient. So in MedCognito, we always say that when you are closing a counseling encounter, give the patient a gift. Which gift are we talking about? Give the gift of a handout so the patient can read more and appreciate it better. Would you like to commit to the plan? Because you want the patient to finally commit to the plan you have. Dr. Sunny, are there
I have a doubt here.
Please ask.
Would you like to do a UPT even though she just had a period 2 weeks ago?
Yes. Don't assume anything in medicine. Don't assume. Never ever assume. Okay. Yeah. So closing remarks. So I have a question before we go on to the final tricks for the day. Any eye-opening concerns, like, have you what do you think about today's session? Anyone? Or Dr. Sunny, what are the things
I found
which
found it extremely informative. So I thought I was having a good history thing, but then I realized that there are so many other things that I could have asked. The only thing that remains shocking for me is how would I cram up all this information in 8 minutes?
You had so
all
much
the questions
time.
that
You had so much time. This
To
question,
be honest, I was not measuring time when I was doing, and this is my first time when
yeah. This particular counseling
the
session.
number of questions.
This particular counseling session is about 11 minutes. And so
we can exceed greater than 8 minutes?
Yes. It all depends on the
then
amount
fine.
of time you are given. Yeah. But this counseling session was supposed to be about 10 to 11 minutes. So let me see some of the comments before we go. The slides covered everything for this case that one could possibly think of. Yes, Dr. Kim. Systemic approach to history taking. Beautiful, doctor. And remember that they are also going to mark how systematic you are. So, Dr. Sunny, I'm not saying you were not systematic. You were. I'm just telling you that. So that's also very critical. Okay. So, how are you going to impress in your clinical encounter? How are you going to do that? Today, I really want to take my time and, get you through it. Number one, first impressions matter. First impressions do matter. So know why the patient is actually there. Okay. And do your best. Put yourself in a position to address the issue. Don't be seen as you have your own agenda. No, don't go with your own agenda. Rather, go with the agenda of the patient. And don't feel rushed. Take your time. Greet the patient by name. Keep eye contact. Pick up the picture. When I say pick up the picture, I'll come to that. Assume the posture of the patient. When I say assume the posture of the patient, what do I mean? If the patient is standing, stand. If the patient is sitting, sit. Don't sit while the patient is standing, because with that, the patient is towering over you. And that means you've made yourself vulnerable. And don't also stand when the patient is sitting, because then it's like you have a paternalistic approach to the patient. So be at the level of the patient. And if you see that there are two chairs and the patient is standing, you just gently suggest to the patient, are you able to sit so that we have a conversation? Don't feel rushed. Number 3, if there is a chat in the room, review it quickly and bring up unique points. What do I mean by that? So, for example, if you go and there's a big file, part of your assessment is that you need to also review the file. And you can say that, look, I see from your chat that you admitted in 2020 for a heart attack. Can you tell me a little more about that? Because the encounter may be around that chat, right? So you want to be careful about that as well. And then seek clarification when you're confused. So, for example, the patient may say something that you don't understand. Don't assume. Seek clarification. So, for example, you say, I'm sorry, I do not quite understand that. Can you state what you just said? Then the patient will clarify that for you. But also don't put yourself in a position where the patient keeps asking you, Doctor, pardon, I didn't get what you said. Can you explain? No. That's not good. That's not a good sign. No. Dr. Sunny, that's not a good sign. You didn't put me in that situation, but I'm just saying that in the main exam, please don't put yourself in that situation. Okay? And then use chronology and sequence to your advantage because you'll be marked on it anyway. So in your mind's eye, from here, I'll go here. From here, I'll go there. From here, I'll go here. In case I miss a step, what strategy will I use to get back without coming across as being disorganized? Right? So, for example, if you miss a particular step, you can go like, Mary, thank you for all the information you've provided. However, I want us to circle back a little bit. Use that expression. I want us to circle back a little bit. If you use, I want us to circle back a little bit, you come across as, somebody who wants to emphasize on something. Rather than you just maybe you've gone through everything, you've gotten to past medical history or even social history, and then you go back to direct questions again. But then you have to use the language. That's what I'm saying. NAC OSCE is all about communication. Dr. Jen is asking, do you get to use a pen and a paper? Yes. You are given a pen and a paper. However, in MedCognito, we guide you in such a way that by the time you are going for the exam, you are getting everything in your mind. You are really looking in the patient's eye and having a conversation. I'm not saying using a pen and a paper is wrong, but what happens is that a lot of people get so fixated on their pen and paper that they forget that there's a patient sitting in front of them. And that is something we teach you to drop, so you can become a better communicator. And be empathetic. Use empathetic language to bring out the patient's deep concerns, which may cause fear. Okay? So, for example, you can say this. Many patients have thoughts about what might be causing their symptoms. Assuming you have somebody who has maybe headaches and all that. I was wondering if you were concerned about anything in particular. You see the language. Or if patient gives you a vague answer, add, what do you think may be going on? Yeah, because the patient may be hiding behind certain things, okay? And then pick up non-verbal cues. What I mean is that if you go in and the patient is worried, pick it up. Tell Mrs. Smith, it looks like you look worried. Or Mrs. Smith, you look very happy. Is there something you want to tell me? Mrs. Smith, is there a reason why you are looking down? Pick up that picture. Or if it's like a wintry day in Saskatchewan and the weather is minus 30 and you go and this patient is just wearing undergarments. This is not right. Mrs. Smith, the weather is cold, but it looks like you're wearing light clothing. Is there a special reason I should know about? Who knows, right? You seem worried about something, right? You seem worried about something, like this patient. You seem, or this one. You seem worried. Do you mind to share what might be bothering you? You realize that all the language we've used so far is simple language. We've not used any complex medical language. No. I was wondering if it feels uncomfortable for you to talk about this. Okay. And there's this thing from William Osler, awesome doctor. He said something. He said, a good communicator allows others to speak too. Let the patient speak, please. Learn to pause and listen to the patient. Because William Osler says that listen to the patient. He's telling you the diagnosis. Okay? Don't be in a hurry to cut in. No. Allow the patient to flow. The patient is a test patient. The patient knows when to say what and what not to say. All right? And then last but not the least, learn to ask for more. When I say learn to ask for more, what do I mean? Mrs. Smith, please, is there anything else you would like me to know? Probe further. Learn to ask for more. Like Oliver Twist. Oliver Twist asks for more.